right. And we are live. Everyone's learning that my tech support is limited here. I'm doing this myself. So, welcome everyone. I am so excited to have you here. We are officially in MHAM since it's the month of June. However, for anyone who saw last week, we started pushing these out, these videos a little sooner, these lives a little earlier because of Mental Health Awareness Month. And so, officially kicking it off today is Dr. Mark Burish. And Dr. Burish, thank you so much for being here today.
Thank
Um,
you for having
yeah,
me.
glad to have you here. We hear that you know all things cluster headaches. So, and I apologize to everyone that I'm going to be toggling back and forth between notes and watching the chat for any questions. So, Dr. Burrish, kick us off with telling us a little bit about yourself, what your background is that made us say, hey, we've got to have you on this today.
So I'm a neurologist, MD PhD by training. So I did a little extra training on the research side. And I've been in practice now for about 10 years here in Texas at the UT Health. I spent about half my time seeing headache patients, about half my time doing research, mainly on cluster headache.
That's amazing. Well, on behalf of all of our patients watching this, thank you for choosing this field of medicine. It's so invaluable to have physicians who are this is their passion area. So thank you. We're just going to start with basics for a minute. For people watching who have heard of cluster headaches, what are cluster headaches?
So the short version is they're bad. There was a study that came out just last month of two women who had childbirth and had cluster headaches around the same time, and they had no epidural or anything for the childbirth. Both of them said that they thought the cluster headaches were worse, and that one woman said, I'd rather give birth 16 times a day than have a cluster headache. So they are incredibly severe. And that's not the only data. There's lots of other kind of anecdotal things and studies that have come out. But what an actual attack is, a single kind of painful event, is that it is one-sided pain, usually around the eye, 10 out of 10 or worse on a scale of 1 to 10 if you think that you can get worse than a 10. And at the same time, you get all these changes around the eye. The eye will water, the nose will run, you get kind of these changes on the same side of the face, and things will be kind of, you'll be very restless. You can't sit still, you kind of have to move around. And the headaches last about 15 minutes to 3 hours, can happen multiple times a day. And then you can get them every single day for weeks and weeks, or even just every single day.
Wow, wow. You know, I'm sure that people end up in the ER a lot thinking this is an aneurysm or something. Does that happen a lot? Am I thinking of that properly? Because it is so painful.
Yeah, and it's a tough thing because if it lasts for 15 minutes, by the time you get into the emergency room, get through the system, it's kind of gone at that point.
Right,
And
right.
so it's hard to explain. I just had this really bad headache, and you're kind of left kind of chasing ghosts almost because there's nothing, usually the imaging is normal.
Yeah, yeah. Wow, that's incredible. I had one of our advocates recently say it was so bad that he said I couldn't even there it's like nothing I've ever felt before. What do you recommend with if somebody says, "Hey, I've had one for one day and now I've had it a second day." Talk a little bit about just getting care for cluster headaches. Like, do you go and call your general practitioner? When do you see a specialist? Talk a little bit about that path.
So cluster headache is fairly rare. It's about 1 in 1,000. We wouldn't call that rare, but it's not the most common thing in the world. So not every provider is going to have a lot of experience with cluster headache. You may get lucky with a primary care doctor who has some experience with it, but you may end up needing a referral to a neurologist who has a little bit more experience. There are headache specialists, and this audience probably knows very well about headache specialists. Those are people who did extra training after their neurology, usually neurology residency, so they have even more experience with headaches. Those are probably the ultimate kind of step up. But usually you'd go to your primary care doctor, then a neurologist, and then if necessary, to a headache specialist.
And how many days does it have to go on before you should seek care? I mean, I've heard, it sounds like they're so unbearable that you're going to want to seek care pretty quickly. But if you had it for 3 days and then you don't have it anymore, do you still go and try to get treatment because it could come back? Talk about that.
Yeah, so you're talking about kind of two things which I think are both fascinating, but one of them is when I have a new headache, when do I go see a doctor? What should I be concerned about? So if you've never had a headache like this before, just the intensity and the location, everything, you should get something like this checked out right away. Now, if you've had this for 10 years, we're not as concerned about you've got to go right away to get somebody checked out. But a headache of this severity, I would go see somebody in the emergency setting. Cluster headache, interestingly, the way it got its name is that headaches will come every day or every other day for weeks or months. And then for most people, it'll then go away for months or years and then come back. So it's as if the headaches are clustering together.
Okay.
So some patients will get them and then they'll go away and they'll say, well, I guess I don't need to see somebody about it. You probably still should see somebody about it because they may come back.
Yeah, yeah. Well, as far as and when they diagnose them, what makes them different from the diagnosis of migraine?
I think the most relevant thing for patients is that they're treated differently. So we really do need to know how they're different because otherwise you'll get the wrong medications. Um, my cluster headache, kind of as a shorthand, I like to think of as one, it's an intense pain, but it has all of these symptoms that go along with like eating a hot chili pepper. I'm in Texas, so that's pretty common for us. But the on the same side of the pain, just like if you eat a hot chili pepper for the whole head, your eyes might get a little watery, it might get a little stuffy. We see that for cluster headache. You can get it for migraine, but it's less common. Migraine, it's a little bit longer. It's about 4 hours, kind of at a minimum, and it can go up to 3 days. And you get more things like sensitivity to light, sensitivity to noise, nausea. The best way I think you distinguish them is cluster headaches are 3 hours or shorter, migraines are 4 hours or longer. Cluster headache, you are very, very restless. You don't want to sit still. You got to get up and pace and move around. Migraine is the opposite. You usually don't want to get up and move around because that'll make the headache worse.
That's I'm actually taking notes because this is so fascinating. I'm like, oh, that's so interesting. They're restless. What causes the restlessness?
We don't know. One person has theorized that it's the same kind of pathway that, when you stub your toe, you kind of hop around a little while and just, God, I can't, maybe it's that same pathway, but no one knows for sure.
Oh, interesting. That's so interesting. Well, someone actually had messaged me in the inbox and said, could you have both migraine and cluster?
Yes, absolutely. I don't
Okay.
think I've had anyone that's had a migraine and cluster literally at the same time. I'm sure that
Ooh,
happened, but you can have kind of both headaches.
wow, wow. That's so interesting. I'd be curious the stats on that. That has to be that's unbelievable. Do we know what causes cluster headaches?
The short answer is no. It runs in families just a small percentage of the time, maybe 8%. So for those of you who are watching who do have cluster headache, chances are you're not going to have a sibling or a child or something with cluster. So it's probably not just an easy genetic, single gene variant that's going to be responsible. There are some genetic risk factors, some genes that increase your risk. For reasons we don't understand, a lot of cluster headache patients are smokers, um, just more than the general population. And a lot of times they've smoked before they had cluster headache. Now, obviously, not every smoker gets cluster headache, but maybe there's some link between some environmental thing like smoking and some, genetic risk factor.
Wow, interesting. That's so interesting. What kind of treatments are available for someone who may be newly diagnosed or maybe hasn't gone to a doctor yet? What can they expect as far as treatments go?
So on the ones where for the haven't seen a doctor yet, I think the only one that's available over the counter that has good data for is melatonin.
Hmm.
There's some studies of melatonin 10 milligrams at bedtime that seem to help. Most of them are going to be prescriptions. Um, we break them up into as needed treatments and preventive treatments, just like we would for migraine. The as needed or acute treatment to break a headache, one of the ones that works really well is oxygen gas. So just the stuff that comes out of the tanks. Now, it should be medical grade, obviously, but it's not just the little nasal cannula that goes in your nose. It's a full face mask, 15 liters per minute, pretty high flow, but obviously very safe unless you're standing next to an open flame or have a couple other kind of rare issues. It obviously very safe kind of thing to do. It's just trying to get it at home is sometimes a logistical issue for people. The other one people use is a medicine called sumatriptan, which is also used by migraine patients. But for cluster headache, the injection works much better than the pill.
Mm,
The headache only lasts 15 minutes. The pill is just going to be too slow. So patients really like the injection. On the preventive side, short-term preventive, something you can take for a few weeks, would be steroids, something like prednisone. Work very well. They do have some side effects, but patients sometimes are willing to accept those side effects of the steroids because the headaches get a lot better. Long-term prevention, our first-line treatment is verapamil, which is a blood pressure medication. And sometimes we scale it up to fairly decent doses because those are the doses that are necessary.
okay, interesting. And is there anything new that's in and being that's just come out for cluster headaches?
Yeah, it's been really exciting. The last 5 or so years, there's been a lot of interest in new drugs and new devices, like wearable and implantable devices for cluster headaches. So on the drug side of things, there's a couple things. There's an injection that you give yourself once a month called galcanezumab. It's also available for migraine, but the dose for cluster headache is a little bit higher. It's an injection you give yourself just when you're having headaches. If you're out of cycle, you don't necessarily need them. There's a device that goes on your neck that stimulates your vagus nerve. So it's a non-invasive vagus nerve stimulator. It's wearable. You hold it up to your neck when you're having a headache, and that can sometimes help break the headache. There's some new things that are being researched. So there's other medications in the same galcanezumab family that people are looking into. It's not legal in Texas at least, but it's been decriminalized in other states and other countries. But something called psilocybin, which is a psychedelic medication. They've been doing some early studies of that to see if it's effective. And then there's been some studies in other countries of ketamine, which is an anesthetic, but that may help break a headache. So there's actually been a lot of exciting stuff. There's even now an implantable stimulator that goes on the back of your head that may help patients, specifically patients with refractory headaches, which means they've tried a lot of other things that hasn't helped.
Yeah, yeah, interesting. Wow, that's exciting though to see new things come into light and that someone people are interested in this. And I know some of these the non-medicated devices are really popping up too to be helpful. So that's fantastic. Do you need a prescription for the things that are not like the vagus nerve stimulator? Do you need a prescription for those things? Okay.
My
Okay.
knowledge, you still do, yes.
Okay. Okay. And so if somebody's watching and they've gone to their general practitioner or family doctor and they're like, I don't really, I really haven't seen these type of headaches before. Your recommendation then is they should try to go see a neurologist. Is that their next steps? You talked about that a little bit earlier, but if they're hearing these new medications too, and they're like, I want to try something new, is that their best steps?
Probably, my guess is with newer medications, you might find a primary care doctor that's very comfortable with cluster headache. If they're one that have kind of a passing knowledge, they may not be as knowledgeable about the new medications.
Okay.
Now, outside, you can obviously do your own research to say, I think I have this. I would like to see a neurologist. There are also some very good community support groups for cluster headache that you can see, if they have some ideas as well. But those groups have actually been very helpful for a lot of people.
That's wonderful. That's sometimes just to have somebody else say, I know this is pretty debilitating and help. It's just so helpful. And I know there's those resources there. How do patients find a doctor who can treat cluster headaches? Since there's not, it sounds like the number's a little smaller, right? With the prevalence being less. How do you find someone who can treat cluster headaches?
So there's not a cluster headache specialist where that all they do is cluster headache. There is for what it's worth, I believe the first ever kind of cluster headache and related diseases clinic in Philadelphia, the Jefferson, that they've been trying to kind of start up a program there specifically like that. But in general, the people who have the most knowledge about this will be headache specialists.
Perfect. That's perfect. Because I don't want people to watch and then go and Google it and say, I don't see one of these doctors. So a headache specialist seems like that's a really good option for people to go to. So that's wonderful. Well, we also know and appreciate that you also are a researcher. Anything you can share that you're working on that's maybe exciting for patients?
Yeah, so one of the things that I've been really fascinated with cluster headache is the timing of the headaches. So patients will tell you, like clockwork, I get it every day at a certain time. For patient number one, it could be 2 a.m. For patient number two, it could be noon, but I can set my watch to it. And I even had a patient who I was asking him all the questions, and he actually just said, it's 3 o'clock. If you want to wait 15 minutes, you can see what it looks like. Like that's how certain he was. I mean, maybe I was asking too many questions, but that's how certain he was about when he was getting his headaches. And so we've started to look into how does that work for these patients? What part of the brain is being activated? How are these medicines working on the circadian system? And we found that several of the medications work on your molecular circadian system in your body. So it's well known that prednisone does. That's kind of a hormone for daytime. Melatonin does. That's your hormone for nighttime. Lithium is well known too. We found that verapamil does, ergotamine does. And so we've been kind of interested in, is this maybe a new target? Is this how we kind of look at treating cluster headache in the future? We're still in early phases, but we're really excited about it.
So exciting. I'm sure patients that are watching are cheering you on because I don't think people realize how much goes on in the background of just getting research, getting things way before clinical trials even take place. So thank you for doing that work. And I guess would you just close us with a word of hope if there are patients watching and maybe they're not on a medication that they're really getting relief from, or just some hope for them if they're discouraged where their path is right now with cluster headaches?
Yeah, cluster headache has, I've seen a lot of patients. I've talked to a lot of research people. The cluster headache is another nickname for it has been suicide headache, just because of the extreme nature of the pain, and just the the care that patients sometimes feel they need. Um, I would say a few things, on the message hope. One is there's some very good people in this field. I'm not saying myself personally, but the other researchers, there's a phenomenal international group that is working on this. The support groups I really have thought very highly of. For cluster headache, a lot of patients have said nobody really can understand what this pain is like. It is so bad. I can't describe this to a neurologist or a psychiatrist or a primary care doctor and do it justice. And so talking to someone else who's gone through it, who actually has the disease, can be really helpful. And research on their side of things, patients are always very happy to participate. The treatments have been coming out faster and faster. Companies, industry has been more and more interested in it. And so I'm just excited about kind of hopefully things exponentially kind of taking off going forward.
Yeah, that's wonderful. That's wonderful. Thank you so much. And as we're sharing today, we want people to have hope that there is another side for this, and that with the right treatment, that we want to see people get the help they need. And so, thank you so much for sharing that with us. I think this is such a great way to kick off MHAM, the official MHAM week. So Dr. Burish, thank you for your time. I'm sure that we want to, there's patients probably waiting to see you that we took you from. So we appreciate that. And as we close up, I just want to tell our audience, this week is actually going to be packed of speakers every day. So make sure you check our Facebook, check your inbox. We have a variety of speakers. It's so exciting. And also, we're going to be doing fundraising throughout the month of June as well. We're hoping to raise $25,000 to come back to American Migraine Foundation. And we'll put the links in the chat to those things as well. But most importantly, we want people to get the resources they need. So if you're new to AMF, American Migraine Foundation, we will leave all sorts of resources for you. So check back. And then we'll also we'll have this recording post on our YouTube channel as well to check back later with. So Dr. Burish, thank you. Thank you to everyone watching. And we look forward to picking this back up tomorrow. And we'll let you get back to the stuff you need to do for our families and patients. So thank you, Dr. Burish.
Thank you.
Thank you. Bye-bye.